Welcome all for today's presentation. Today we will have recall and revise series for part 2 of MRCOG. The examination is very close. I wish you best of luck and we'll solve these recall questions. Dr. Sinchana, can you read this particular question and solve the question?
Yes, sir. A 30-year-old pregnant woman at 32 weeks gestation is diagnosed with intrahepatic cholestasis of pregnancy and is started on ursodeoxycholic acid. She asked about possible side effects of this medication. What is the most common side effect of ursodeoxycholic acid? Options: A. Pruritus worsening, B. Hepatotoxicity, C. Gastrointestinal upset, D. Alopecia, E. Bone marrow suppression. It is C. Gastrointestinal upset.
Yes, they are asking the most common. Okay, remember what they are asking. Okay, it is the most common they have asked. So GI upset is the most common. So here most common is a GI upset, including diarrhea, nausea, abdominal discomfort, etc., etc. Okay, but serious adverse effect will be hepatotoxicity or bone marrow suppression. They are rare. So always remember what they have asked, whether it is a serious adverse effect has been asked or the most common. Okay, go ahead with the next question. We'll go little faster. Okay. Yeah.
Yes, sir. 42-year-old primary gravida presents for antenatal care at 10 weeks gestation. She is otherwise healthy with no pre-existing medical disorders. The pregnancy is progressing normally so far. Which of the following is the most significant complication associated with very advanced maternal age? A. Preterm labor. B. Antenatal hospital admission. C. Gestational diabetes mellitus. D. Preeclampsia. E. Caesarean section. It is
There is a
D
separate.
pre.
Yeah, yeah.
Yes, D
What
pre-eclampsia.
is your answer?
D, sir. D pre-eclampsia.
Uh, I think this is the cesarean section. There is a separate talk on the very advanced maternal age, and we have covered this particular talk most probably. But there is a chart. Okay, so let's see the
Yes.
what is the answer. Correct answer is C, caesarean section. E, caesarean section. Very advanced maternal age, more than 40, is associated with severe pregnancy complications. There is a high caesarean section rate in these patients, okay, including gestational diabetes, hypertensive disorders, preterm birth, and increased antenatal abdomen admissions. However, the most consistently and significantly is increased outcome is a higher rate of caesarean section due to factors such as labor dystocia, reduced myocardial efficiency, increased fetal surveillance, and low threshold for operative delivery. Okay, go ahead with the
Yes,
next
sir.
question. Please
34-year-old.
message this particular talk very advanced maternal age. I'll post you the that chart. Okay,
Yes.
this very advanced maternal age. Okay.
A 34-year-old woman presents with secondary amenorrhea. She had oligomenorrhea from age of 32 years, followed by amenorrhea for last 8 months. She has 2 children, no past obstetric complications, and no significant medical comorbidities. She is not using hormonal contraception. Urine pregnancy test is not included in the options. What is the most suitable initial investigations? Options are A. Serum prolactin, B. 17-hydroxyprogesterone, C. FSH, LH, and serum estradiol, D. Dexamethasone suppression test, E. Pelvic ultrasound. So it is E. Pelvic ultrasound.
Here actually see this is a secondary amenorrhea. Specifically the urine pregnancy test they have not included. Ideally any amenorrhea in young reproductive age group we will select the urine pregnancy test. Okay, first we'll
Yes,
do,
sir.
but that is not there. Now she is 32 years and there is a oligomenorrhea followed by amenorrhea. Okay, and in these patients we are suspecting premature ovarian failure. Okay, now, if we are suspecting premature ovarian failure, then the first option uh, will be
FS,
hormonal
FSH,
investigations. Okay.
hormonal.
hormonal investigations. Here you just apply some logic. What will give you the information? Now pelvic ultrasound with this particular history, what we are suspecting? Are we suspecting anything with the pelvic ultrasound? Okay. So unlikely, the most will be the FSH, LH in this patient and serum estradiol. Okay.
Instructor.
So FSH levels, if a woman under 40 years with progressive premature ovarian insufficiency is an important diagnosis to exclude. The most appropriate initial investigation will be hormonal profile. Okay. Raised FSH LH with low estradiol will suggest POI. Okay. Prolactin for hyperprolactemia, etc. Okay. 17 hydroxyprogesterone is used to investigate congenital adrenal hyperplasia. DEXA suppression test is indicated in suspected Cushing syndrome. Okay, pelvic ultrasound provides structural information but does not assess endocrine ovarian function and is not the first line test in this scenario. Okay, so that will be a routine test, but pertaining to this, the most appropriate will be hormonal evaluation. Okay,
Yes, sir.
go ahead with the next.
Yes, sir. A 28-year-old woman presents with recurrent pregnancy loss. A congenital uterine anomaly is suspected. She has no significant medical comorbidities. What is the most appropriate investigation for diagnosis of a uterine anomaly? A. Two-dimensional transvaginal ultrasound. B. Hysterosalpingography. C. CT. D. MRI. E. 3D TVS. The most appropriate actually will be 3D TVS for uterine anomaly.
Yeah, here the appropriate answer will be 3D TBS. Okay, here we are suspecting on the this particular history of recurrent pregnancy loss, and we are suspecting this. Then for evaluation, we'll go ahead with the 3D TBS. Correct answer is a 3D TBS. 3D TBS is the investigation of choice for diagnosing uterine anomalies. It allows simultaneous assessment of the endometrial cavity and the external uterine counter, enabling accurate differentiation between septate, bicornuate, arcuate, and other Mullerian anomalies. 2D TVS may miss subtle anomalies and cannot reliably assess the fundal counter. Okay, HSG visualizes only the uterine cavity and cannot define the external counter. MRI is highly accurate, but is generally reserved for complex cases or when the ultrasound findings are inconclusive rather than the first line. Okay, CT scan has no role due to radiation exposure and poor soft tissue characterization. Okay. Next. Yeah.
A 30-year-old African woman is reviewed on postnatal ward following a vaginal delivery. She has persistently elevated blood pressure readings in postnatal period and requires antihypertensive therapy. She is otherwise well and wishes to be breastfed. What is the most appropriate antihypertensive agent for her? Option A, enalapril. Option B, labetalol. Option C, methyl-dopa. D, hydralazine. Or E, nifedipine. So it is option E, nifedipine. We don't give enalapril in African.
Correct. That was the point which is important because NICE guideline clearly mentions that in Afro-Caribbean women, this AC inhibitors and other antihypertensives are not suitable. Nifedipine is the drug of choice. Okay, so nifedipine in African or Caribbean calcium channel blockers are preferred first-line antihypertensive agents in the postnatal period. Nifedipine is effective, safe during the breastfeeding, and recommended by NICE for postnatal hypertension in this population. Enalapril is commonly used postnatally, but it is less effective first-line therapy in African origin women. Okay. So labetalol widely used antenatally, but not a first line in African, and it has got a reduced efficacy. Okay. Methyl dopa to be avoided. Hydrazine is reserved for acute severe hypertension, not for maintenance therapy. Okay. So analyze the other options also. Okay. Next.
Yes, sir. A 35-year-old woman with Lynch syndrome has completed her family and seeks advice regarding risk-reducing surgery to prevent gynecological malignancy. She is asymptomatic and wishes to understand the optimal timing to achieve maximum benefit. At what age is risk-reducing gynecological surgery most effective in women with Lynch syndrome? Option A 30, B 35, C 40, D45, E after menopause. So it is D45,
Lynch syndrome,
Lynch syndrome.
a risk reducing surgery is 40. There's a separate, this also you please message me. I'll post you this particular talk. Okay.
Yes, sir.
So
Yes.
answer is C40. Women with Lynch syndrome have significantly increased lifetime risk of endometrial and ovarian cancer. Evidence and international guidance, including RCOG, BSG practice, suggests that risk-reducing hysterectomy with bilateral salpingo-oophorectomy is most effective when performed at around 40 years of age. Actually, it's not a hysterectomy. These patients should, this Lynch syndrome will undergo this TH also. Okay. Once the childbearing is complete, surgery before this age offers less additional benefit and exposes women to earlier surgical menopause, while delaying surgery beyond 40 years increases the risk of developing malignancy before intervention. Okay. So if you delay, uh, there may not be any benefit. Okay. So
Yes, sir.
when you message, no, I'll try to give this particular talk also with the justification also from the talk. Okay, so you can
Yes,
note
sir.
it down. You can, if you have a pen and paper or in the mobile, just note down
Yes,
something.
I'm noting down, sir. Yes.
Yeah, because there is a less time, no, it will help you. Okay. Yeah.
Yes, sir.
Next,
A
go ahead.
36-year-old woman presents with persistent vulval discomfort and soreness. Examination reveals a well demarcated erythematous red lesion on the vulva. The surface appears smooth with little or no scaling, attributed to maceration in moist vulval environment. What is most likely diagnosis?
No,
Vulval eczema.
there is no lesion here, but in the examination they'll give you the lesion also. Okay.
Yes,
Yeah.
sir. Option A, vulval eczema. Option B, lichen planus. C, lichen sclerosis. D, vulval candidiasis. E, psoriasis. So because they have given persistent vulval disc and soreness, it is more towards vulval candidiasis.
No,
86.
the lesion, whatever the description they have given, it is a very typical description. And in the talk, there is a proper figure also. Image is also there, but image is not attached here. But with this also, we should be able to diagnose.
Lichen planus B.
See, the answer is psoriasis. The vulvar psoriasis is characterized presence as a well-demarcated bright red plaque. Unlike psoriasis elsewhere on the body, scaling is often minimal or absent on the vulva due to maceration, making the lesion appear smooth. Okay, vulval eczema is usually poorly demarcated and intensely pruritic, often with excoriations. Lichen planus commonly causes erosive lesions with pain and vaginal involvement. Okay, this we have gone into the detail. Okay, this vulval lesions. Okay, if I have shared my PPT, please go through those because only last couple of PPTs I have not shared, but most of the PPTs I have shared. Okay, so lichen
Yes, sir.
sclerosis will present with porcelain white atrophic skin. Okay, so this is very typical of lichen sclerosis and architectural distortion. Vulval candidiasis typically causes erythema with satellite lesions and
Satellite
discharge.
lesions
Okay,
and discharge.
these are the buzzwords. Okay, they should point it out towards the diagnosis. Okay, next.
Yes, sir.
Sorry, will go little up.
PTG.
Yeah, yeah.
A cardiotocography trace from women in established labor is shown. Based on CTG features, how should this CTG be categorized?
Can you see this? Read it, or you want magnification? I'll try.
No, sir,
Okay.
I can
Yeah,
read it.
you can, yeah.
Sir, it is a suspicious CTG because I'm feeling I'm seeing the variability is increased. It is more than 25. One amber, this
No,
thing.
doctor. Variability is maximum here. It is 20. Okay, not more than that. 5 to 25 is normal variability. Okay, so it is a normal CTG. This is completely normal. You will get CTG 2 or 3. There was once there were 5, 6 CTG questions. Okay, in one of the exam. Generally, what happens? There is a legal imbalance. You will find that there are many questions on a particular topic. There were many questions on the cord prolapse and breach in one exam. There were many questions on the CTGs, and what we have seen, there will be question on the image, there will be question on the aerodynamic chart, there will be question on CTG. So you will be given the chart, so you should be able to interpret it properly. Okay,
Yes.
so make a practice of this. Hardly few days, are in fact it is few hours now. Okay, so those charts, how to interpret and all, they should be in front of you always. Okay, this is a normal CTG, completely normal CTG. Okay,
Okay, sir.
this is a normal CTG. Normal CTG is characterized by fetal heart rate between 110 to 160, baseline variability of 5 to 25, presence of accelerations, reaction, but it is not mandatory, okay, to have the acceleration to say that it is normal, okay, but there is an absence of deceleration, or only early decelerations are also okay. Okay, when all features are reassuring, the CTG is categorized as normal, and routine intrapartum care should continue without additional intervention. Okay. Next. Yes, this one.
58-year-old woman on long-term warfarin therapy for atrial fibrillation is scheduled for an elective endometrial polypectomy. She has stable INR control and no history of thromboembolism in last year. When should warfarin be stopped prior to the procedure? Options:
Yeah.
24 hours before the procedure, 48 hours before the procedure.
Hmm.
Options are not seen.
Okay. Okay. Now, can you see now?
Oh, yes, sir.
Yeah.
72 hours before the procedure, 3 days before the procedure, 5 days before the procedure. It is 5 days before the procedure. Warfarin.
Yes, yes. Warfarin 5 days before the procedure. Okay. This talk also we have gone into detail. Recently we have finished. Okay. So
Yes, sir.
option E, 5 days before the procedure, warfarin should be stopped 5 days prior to the procedure with the risk of a bleeding, such as pulpectomy, to allow the INR to fall to a safe level below 1.5. Shorter intervals are insufficient due to warfarin's long half-life. Bridging anticoagulation with low molecular weight heparin is considered only in patients with high thromboembolic risk, which is not indicated in this scenario. Next.
28-year-old Rh negative woman had a negative anti-D antibodies in early pregnancy. During routine monitoring at 36 weeks, her anti-D antibody level is 16.5 international unit per ml. She delivers a baby at 37 weeks. Neonate is clinically well at birth. Which of the following complication is the baby at greatest risk of developing? A. Early neonatal anemia. B. Early neonatal jaundice. C. Late neonatal jaundice. D. Late neonatal anemia. E option is not visible, sir.
It is a polycythemia, is a E option. All these questions we have
It
covered, they
is
are all big. Yes. What is your answer?
early neonatal anemia.
She is Rh negative, isoimmunized lady. Her titers at 36 weeks are 16.5.
Right.
She delivers. Okay. At term, she is delivered 37 weeks. So what she is likely, what the baby is likely to have? Actually, this is very confusing questions, and every set of student will give different kind of answer, and practically even we do not know what exactly the answer is. What we expect in this patient? See, answer can be either early jaundice or it could be late neonatal anemia.